Hi, thank you very much for the invitation to come to Bangkok to present. Okay, so yeah, discussion show. I'm giving this talk on behalf of Pulmonx. So I'm going to refocus. We've been talking a lot about lung cancer. We've been talking a lot about big three. I'm going to talk about the little one of the big three, COPD, which had the least attention, but it is a big problem. So in the UK, we have an estimated 3 million people with COPD. It's a very big problem, second biggest cause of hospital admission, but yet two-thirds of those patients are technically undiagnosed. They're walking around breathless. They just assume they are smokers, that they don't have a diagnosis, are untreated. A sixth of them have severe COPD. But what we perhaps forget is this severe COPD is not a benign condition, but is also very, very treatable. So if you look at conservative management of these patients with severe COPD, they have a risk of death of 50% in 5 years. That's the same as stage 2 lung cancer. It's not benign. But yet, if you intervene with lung volume reduction, we have a hazard ratio improvement in survival of 50%. That's better than most of the very expensive oncological treatments we have for stage 2 lung cancer. So why aren't we offering this to more patients? So how do we identify the patients who will benefit from lung volume reduction? Well, we're looking for patients who are symptomatic. We know from the NET trial, which is now over 20 years ago, the patients who benefit are the ones who have the least exercise tolerance. They have to have lungs that are too big for them. If they're not too big, there's no point reducing anything. And they need an area for reduction. They need a part of their lung which is not functioning that is dispensable and we can get rid of. The two ways which we can reduce the excess volume, the classical way from the NET trial 20 years ago is to do lung volume reduction. You resect the part of the lung which is emphysematous and destroyed and just taking up unnecessary volume in the chest. But in the last 10 years, there's the way of endobronchial valves. The idea is you put a valve into the bronchus, then air goes only one way. It comes out of the lobe and it can't get back in. And over time, that lobe collapses. And if you put the valves into the lobe which is not functioning, you don't lose function, that lobe collapses, and you get overall volume reduction in the chest without surgery. We've seen in the endobronchial valve reduction that they, just like the surgical lung volume reduction, they have an improvement in lung function, they have improvement in their functional capacity, and they have a better quality of life. There are very few operations we do which we remove things and they get better function. Now, we have something that's very powerful, but is very underutilized. In the UK, we have 43,000 lung cancer patients diagnosed each year, and we do 8,600 lung cancer surgery. At the same time, we have 4 times as many severe COPD patients, and we do 20 times fewer operations for them. Why is that? There are lots of hidden patients. Remember, I told you 2/3 of these patients are undiagnosed. They're walking around, they don't know they have COPD. So there's been a lot of effort trying to find these patients to help them. So we go finding these patients. One of the ways is to look for them in the lung function lab. Patients who have very hyperinflated lung or very bad COPD, we pull them out, do the CT, and maybe about a quarter of them are suitable for this treatment. But then these are patients who are visible. They have a diagnosis of COPD. The other way is to go to the prehabilitation rooms. So patients who have bad COPD and need pulmonary rehabilitation, come, let's do your lung function test and do your CT. And the yield is not good. It's less than 1 in 5 patients we find that are helpful. So we need a better way of trying to find these patients. Well, as it happens, when you do your imaging, you get the information of whether the patient is hyperinflated, because the imaging will show big lungs, and you can see where the target areas, because you see the areas that are grossly emphysematous. Also, it happens that when we do lung cancer screening, when they come in for the targeted lung health check, they have an interview and they go and do the risk modeling. And 2 questions we ask along with the risk scoring model is, how bad is your breathlessness? And they also get spirometry. So we now have all 3 pieces of information we need to find these patients from the targeted lung cancer screening. We know whether they're symptomatic, we know whether they have big lungs, and we know whether the lung is destroyed. So 2 years ago, a bunch of European societies in surgery and respiratory medicine came together and come up with this guideline to look at what to do with incidental findings from CT screening for lung cancer for the other things they find. It concluded it would be prudent to refer patients with moderate to severe emphysema for clinical assessment. That's a very weak proposal, because I argue that there is something that you could do very effectively for these patients, and it would be prudent to refer means it's optional. So we try to see whether we can fish these patients out of the CT screening. So we've done two very small pilots. So we look at the Liverpool data. There are 40,000 CT scans. About 1.5 of them have on the CT criteria severe emphysema. We look at them. About half of them have severe symptoms. So we put those scans into the Stratix system. So Stratix is a AI-driven software that is used on a CT in order to find out whether a patient is suitable for endobronchial valves. It's quite useful because it uses the voxel density to decide who has severe emphysema, and the criteria for a target is either over 50% of the voxels less than 910 or 30% at 950. So you can see here there are targets for this patient. Also, conveniently, it gives you the measured volume from the CT. So the normal lung volume of you and I are about 6 liters. This patient has 10 liters of lung volume. So you can see from the lung cancer screening CT, we know who is hyperinflated and where the target is almost ready for the procedure. And looking at that, almost all the patients who are symptomatic fall into that category. So it's a very high yield finding of the patients. We did that with the BARTS data as well. So we have 7,000 scans from one of the regions in our cohort, and 3.5 of them, sort of 1 in 30 of the patients have severe emphysema on the scan, and a third of them have very bad symptoms. And again, 75% of those patients. We probably just found the same number of patients out of this that we normally operate on in a year. They were so rare before. So a potential way of trying to use this to actually get to the end of treating patients who can benefit from treatment is to scan them, and then out of the criteria, select for patients with severe emphysema score and who are very breathless, bundle those scans into a Stratix, and then identify those patients. You don't even need to, not even the patients who are not suitable for LVR. Well, at least you found them, they have COPD. You can send them for smoking cessation, start them on inhalers, give them pulmonary rehabilitation. Pulmonary rehabilitation in about 10% of the patients make them significantly improve without needing a procedure, and then offer them surgery and valves if needed. So in summary, lung volume reduction is very effective treatment, but it is grossly underutilized, partly because 2/3 of the patients are undiagnosed, same as early lung cancer. Current routes of referral are random and inefficient, whereas screening provides a way of finding all these patients who are treatable. Severe emphysema, it predicts hyperinflation, and what we ask for is for the recommendation to be stronger and not make it optional for the referral on of these patients. Thank you.